Welcome to the deep dive. Today, we're really getting into a condition that's often misunderstood, rheumatoid arthritis, RA.
That's right.
For a lot of people, it just sounds like, joint pain, maybe something older people get. But our deep dive today, using all the great material you sent us, articles, research notes, it shows it's much, much more complex than that.
Absolutely.
So we're going to unpack exactly what RA is, how it's really different from other kinds of arthritis, what the latest thinking is on causes, how doctors actually pinpoint it.
The diagnosis part is key.
Definitely. And the treatments, which have come a long way, and even how things like diet and lifestyle can make a difference. It's a major autoimmune disease, and, well, our goal today is to make you really well informed. Okay, let's unpack this.
And it's so important. What's fascinating here, I think, is just how much our understanding of RA has evolved. We've moved from just sort of symptom management to really trying to tackle the root causes.
Right.
And the sources we have cover so much ground, from the basic science, what's actually going wrong in the body, to the very latest in diagnosis and therapies. We'll try to break down that complexity for you.
Okay, so let's kick things off with the big one. What is rheumatoid arthritis, fundamentally?
Well, the core thing to understand, based on all our sources, is that RA is a chronic, meaning long-term autoimmune disorder.
Autoimmune, that's the key word, isn't it?
It really is. Think of it like this. Your immune system, which is supposed to protect you, gets confused. It mistakenly identifies your own joint tissues as foreign invaders and starts attacking them.
Wow. Okay, so the body's own defense system turns on itself.
Precisely. And while it primarily hits the joints, causing that warmth, swelling, pain, and that really characteristic stiffness that's worse after rest, like first thing in the morning.
That morning stiffness sounds rough.
It can be very debilitating. But, and this is critical, it doesn't always stop at the joints. RA is systemic.
Systemic, meaning it can affect other parts of the body too.
Exactly. It can extend to the skin, eyes, lungs, heart, even nerves and blood. It's not just localized joint trouble. And unlike a sudden injury, RA usually creeps up gradually, developing over weeks or maybe months. And once it's established, it's generally considered a lifelong condition.
Okay, lifelong but treatable, as we'll get into.
Very treatable now, yes. But that autoimmune attack, that's the core mechanism. It leads to inflammation, serious inflammation, and thickening of the joint lining, the synovium.
It's a synovium, right.
And if that inflammation isn't controlled, it starts to damage the underlying bone and cartilage within the joint. That's what leads to the long-term damage and deformities we sometimes see.
Which brings us to a really common point of confusion. How is this different from osteoarthritis, or OA? Because lots of people hear arthritis and think of OA.
That's a crucial distinction. They both involve joints, but they are fundamentally different beasts. Let's break it down. First, the cause. We've said RA is autoimmune. The immune system is the problem. OA, on the other hand, is mostly mechanical. It's wear and tear on the joints over time, like treads wearing thin on a tire.
So internal attack versus external wear.
That's a great way to put it.
Yeah.
Internal system failure versus mechanical breakdown. Then there's prevalence. OA is incredibly common, affects millions. RA, much less common, maybe only affects about 1/10 as many people.
Okay.
Age of onset is another clue. RA can start at pretty much any age, even childhood, though middle age is common. OA usually starts later in life, often linked to aging or maybe a previous joint injury.
And how fast it comes on.
Good question. RA tends to develop relatively quickly, weeks to months. OA is typically a much slower burn, developing over many, many years.
Okay, makes sense. What about the symptoms in the joints?
With RA, think inflammation. Joints are swollen, often warm, tender, and very stiff. With OA, joints usually ache, might be tender, but there's typically little or no significant swelling. The inflammation is much more pronounced in RA.
And the pattern, you mentioned symmetry earlier.
Yes, the pattern is really distinctive for RA. It often affects joints symmetrically. So both hands, or both wrists, or both knees, like a mirror image.
Okay.
OA often starts on one side, maybe in one knee or one hip. It might spread, but it doesn't usually have that classic symmetry. It might affect, say, the finger joints near the nails, or the thumbs, or weight-bearing joints.
And that morning stiffness again.
Ah, yes. Both can have it, but the duration is key. In RA, it typically lasts longer than an hour, sometimes much longer. Really makes it hard to get moving. In OA, it's usually less than an hour, and it might come back later in the day after activity.
Got it. Less than an hour for OA, more than an hour for RA, generally speaking.
Generally, yes. And finally, those whole body symptoms. Fatigue, feeling generally unwell, maybe a low-grade fever. These are common in RA because it's a systemic inflammatory disease. You usually don't get those whole body feelings with OA, which is mechanically focused on the joint itself.
That's a super clear breakdown. So yeah, the bottom line is RA is the body attacking itself, systemic inflammation, versus OA, which is more like physical degeneration from use over time. Different causes, different patterns, different treatments needed. Okay, let's unpack this. Or rather, we've unpacked that part. Hashtag tag 2. The complex web of RA causes and risk factors. Right, so we know what it is and what it isn't. But the big question is why? What actually causes rheumatoid arthritis? What makes the immune system go rogue like that?
Yeah, the why is, well, complicated. The sources are clear. There's no single smoking gun. It's really understood as a complex interaction, a combination of your genetic background and various environmental triggers or factors.
So nature and nurture, basically.
Exactly. It's an interplay. Let's talk genetics first. Family history definitely increases the risk, maybe 3 to 5 times higher, if a close relative has RA. And genetics seem to account for a pretty significant chunk, maybe 40 to 65%, of the risk for what's called seropositive RA. That's RA with certain antibodies in the blood. For seronegative RA, where those antibodies aren't present, genetics seem to play a smaller role, maybe around 20%. And there are specific genes involved, most notably the HLA-DRB1 gene. Certain variations of this gene, sometimes called the shared epitope, are strongly linked to RA risk. These genes help your immune system tell self from non-self.
So if you have certain versions, your immune system is more prone to making that mistake.
That seems to be the case. It creates a susceptibility. And these specific gene variants aren't just linked to getting RA, they can also predict, to some extent, how severe the joint damage might be, or how high inflammation levels might get.
But genes aren't the whole story, right? You mentioned twin studies.
Right. This is fascinating.
Yeah.
Identical twins share 100% of their genes, but if one twin gets RA, the other twin only gets it about 12–15% of the time if they were raised apart. That tells us genetics load the gun, but environment often pulls the trigger.
Okay. So what are these environmental triggers? Here's where it gets really interesting.
Well, one of the biggest and most established environmental risk factors is smoking.
Smoking. Really?
Absolutely. Smoking can triple the risk of developing RA. It's particularly risky for men, heavy smokers, and those who eventually test positive for rheumatoid factor. And get this, the interaction with genetics is powerful. If you smoke and you carry 2 copies of that high-risk HLA-DRB1 gene variant we mentioned, your risk of RA can be over 20 times higher than someone who doesn't smoke and doesn't have those gene copies.
20 times. Wow, that's a huge interaction.
It really highlights how genes and environment can conspire. Another inhaled risk factor is silica dust exposure. Think miners, stonecutters, sandblasters. It's the second most common non-smoking inhaled risk, especially linked to seropositive RA in men. And it might even interact with smoking to increase risk further.
Okay, so inhaled substances are definitely implicated. What else?
Body composition, specifically obesity. A higher BMI, more body fat, especially around the waist, is a clear risk factor. Fat tissue isn't just passive storage. It's metabolically active. It acts almost like an endocrine organ, releasing inflammatory substances, cytokines like IL-6, TNF-alpha, CRP, and hormones called adipokines like leptin.
So fat cells can actually fuel inflammation.
They absolutely can. Leptin, for example, can interfere with the immune cells that normally keep things in check, while adiponectin can promote cells that break down bone. There's even a condition called sarcopenic obesity, increased fat, decreased muscle common in RA patients, which further complicates things. It's not just about the weight on the joints. It's about the inflammatory signals.
Interesting. What about infections? I've heard theories about that.
Yeah, infectious agents have been looked at for decades. No single virus or bacterium has been definitively proven to cause RA across the board. However, there's a consistent link with periodontal disease, gum disease.
Gum disease? How could that be linked?
The leading theory involves bacteria in the mouth, particularly one called Porphyromonas gingivalis. This bacterium can trigger a process called citrullination, modifying proteins in a way that might make the immune system see them as foreign, leading to the production of those ACPA antibodies we see in RA. It's an active area of research. Also, changes in the gut microbiome are implicated. The certain bacteria, like Prevotella copri, have been found more often in people with new-onset RA.
The gut connection again, it seems to pop up everywhere.
It really does. And finally, we have to mention reproductive factors in women. RA is much more common in women, especially before age 50, maybe 2 to 4 times more. And about half of RA cases start during a woman's reproductive years.
So hormones likely play a role.
It seems very likely. Hormonal fluctuations during pregnancy, postpartum, menopause, even using external hormones, These can all influence the immune system. Interestingly, symptoms often improve significantly during pregnancy for many women.
Oh, really?
Yes, for maybe 75% or more. But then they often flare up again quite badly after delivery. The exact mechanisms are still being worked out, but the connection to female hormones is pretty clear.
So what does this all mean? It's not one thing. It's this intricate mix. Your genes set a certain susceptibility level, and then things you encounter are internal states like smoking, infections, maybe your gut health, your body composition, hormone levels. They all interact to potentially push someone over the threshold into developing RA.
That's a perfect summary. A dynamic interplay.
Okay, we've got a handle on what RA is and the complex factors that might cause it. Now let's dive into what it actually feels like and where it shows up in the body. You mentioned it's systemic, right? So is RA just about joint pain? Clearly not.
Definitely not just joint pain, although that's often the most prominent symptom. Let's start there with the joint symptoms. The absolute hallmark is that inflammation of the synovium, the joint lining.
Right, the synovitis.
Exactly. That leads to joints feeling swollen, tender to touch, often warm, and definitely stiff. That morning stiffness we talked about, lasting over an hour, is a classic sign, or stiffness after sitting for a while. Gentle movement might help ease it initially.
Which joints are typically involved?
It's usually a symmetrical polyarthritis, meaning multiple joints on both sides of the body, often the small joints of the hands and feet, the wrists, elbows, ankles, the balls of the feet, but larger joints like shoulders, knees, even the cervical spine and the neck can be involved too.
And what happens over time if it's not treated effectively?
Well, that chronic inflammation does damage. It can cause tendons to tether or even rupture, and it erodes the cartilage and bone within the joint surface. This leads to instability, loss of motion, significant pain, and eventually characteristic deformities.
Like what kind of deformities?
You might see fingers drifting sideways towards the pinky, that's ulnar deviation, or specific finger joint issues like swan neck or boutonniere deformities. The thumb might develop a Z shape, hammer toes in the feet. In very severe, long-standing cases, it can lead to arthritis mutilans, where there's extensive bone destruction. The pain itself is what we call nociceptive, directly from that tissue, inflammation and damage.
Okay, so significant joint impact. But what about beyond the joints, those systemic effects?
The constitutional symptoms. People with active RA often feel generally unwell. Profound fatigue is a huge one, often described as overwhelming and not just related to poor sleep. A low-grade fever, general malaise, that prolonged morning stiffness, sometimes loss of appetite and weight loss too. These signal body-wide inflammation.
And then the specific organ involvement, the extra-articular manifestations. Okay, let's unpack this. Where else can RA strike?
It can show up in many places. On the skin, the most common feature besides the joints are rheumatoid nodules. These are firm lumps, usually painless, often over bony areas like elbows or knuckles. About 30% of people with RA get them, and they tend to be associated with more severe antibody-positive disease. Rarely they can form internally, too.
Nodules under the skin.
Okay. More seriously, RA can cause vasculitis, inflammation of blood vessels. This can lead to skin ulcers or nerve damage if blood supply to nerves is cut off. It's usually seen in long-standing, poorly controlled disease.
What about the lungs?
Lung involvement, rheumatoid lung disease, is quite common actually, though not always symptomatic initially. It can cause scarring or fibrosis of the lung tissue. There's also Kaplan syndrome lung nodules in RA patients with coldest exposure. Fluid around the lungs, pleural effusions can happen. And rarely, some RA meds can affect the lungs too.
And the heart. You mentioned increased risk earlier.
Yes, the heart and blood vessels are a major concern. RA significantly increases the risk of atherosclerosis, hardening of the arteries, leading to a much higher risk of heart attack and stroke. This seems driven by the chronic inflammation itself. Other issues can include inflammation of the heart sac, pericarditis, the heart lining or valves, endocarditis, valvulitis, and even heart failure. Managing RA inflammation is critical for cardiovascular health.
That's serious. What else? Blood, kidneys.
In the blood, anemia is very common, usually anemia of chronic inflammation. Less often, a low white blood cell count, Filty syndrome, or high platelet count, signaling inflammation. The kidneys can be affected, sometimes by amyloidosis from chronic inflammation, or historically by certain older drugs. Eyes can get very dry, keratoconjunctivitis sicca, or secondary Sjogren's syndrome, which can be severe enough to damage the cornea. More serious inflammation like scleritis can also occur. Neurologically, peripheral neuropathy, nerve damage in hands, feet, can happen. Carpal tunnel syndrome is very common due to wrist swelling compressing the nerve. And a serious, though less common issue is instability in the neck vertebrae. atlantoaxial subluxation, which can compress the spinal cord. That's a neurological emergency.
Goodness, it really can touch almost any system. Bones, cancer risk.
Yes, bones suffer too. Osteoporosis can develop locally around inflamed joints due to inflammatory chemicals, and systemically due to inflammation, immobility, and steroid use. There's a slightly increased risk of lymphoma, a type of blood cancer, thought to be linked to the chronic immune stimulation of RA itself. And gum disease, periodontitis, is much more common in people with RA.
Wow, it really paints a picture of RA as a far-reaching condition. It's absolutely not just joint pain. #IV. Unraveling the diagnosis of RA. Okay, so given this complexity and how it can mimic other conditions, how do doctors actually nail down a diagnosis of rheumatoid arthritis? It sounds like it could be tricky.
It can be, especially early on. There isn't one single test that says, yes, it's RA. It's really about putting together pieces of a puzzle. The patient's symptoms and history, a physical exam, imaging results, and specific blood tests.
Let's start with the blood tests. What are they looking for?
The classic one is rheumatoid factor, or RF. It's an antibody found in about 2/3 of people with RA. But here's the catch. It's not very specific. Meaning it can be positive in people without RA, maybe 10% of healthy folks, or people with other infections like hepatitis C or other autoimmune diseases. And importantly, it can be negative in early RA, maybe for the first year or so. Some people with definite RA never test positive for RF.
So a positive RF doesn't guarantee RA, and the negative one doesn't rule it out.
Exactly. That's why the discovery of anti-citrullonated protein antibodies, or ACPAs, often called anti-CCP, was such a breakthrough.
Okay, ACPAs, how are they different?
They're found in maybe 60–75% of RA patients, similar to RF, but they are much, much more specific to RA, around 95% specificity. If you test positive for ACPA, there's a very high likelihood you have RA or are developing it.
And you said they can show up early.
Yes, often years before symptoms even start. That makes them incredibly valuable for early diagnosis and predicting who might develop more severe disease. They are a real game changer.
So to answer that question explicitly, can you have RA without positive blood tests?
Absolutely, yes. About 1/3 of people with RA are seronegative, meaning both RF and ACPA are negative. Diagnosis in these cases relies more heavily on the clinical picture, the pattern of joint involvement, the symptoms, imaging findings, and ruling out other conditions.
Are there any newer blood markers being used?
Yes, research is ongoing. One marker gaining traction is 1433, or YWHH. Studies suggest it can complement RF and ACPA, potentially helping with early detection or assessing risk, especially when the other markers are borderline or negative. It adds another piece to the puzzle.
Okay. What about general inflammation markers?
Right. Tests like erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, are usually checked. They measure general inflammation in the body. In active RA, these are typically elevated. They aren't specific to RA, but high levels support the diagnosis and help track disease activity over time. Other routine tests, blood counts, kidney and liver function help rule out other issues or monitor for medication side effects.
Makes sense. What about imaging, like X-rays?
X-rays of hands and feet are standard. Early on, they might look normal or just show subtle signs like soft tissue swelling or maybe some bone thinning near the joints, osteopenia. Later, they show the characteristic bony erosions, the little bites out of the bone, and joint space narrowing, or even subluxation when the joints become misaligned.
But X-rays might miss early damage.
They can, yes. That's where ultrasound and MRI come in. Ultrasound, especially with Doppler to show blood flow, is much more sensitive for detecting early synovitis, that active inflammation in the joint lining, and also early erosions, maybe picking up 20% more than X-rays.
Yeah.
Active inflammation on ultrasound is a strong predictor of future joint damage.
Yeah.
MRI gives incredibly detailed pictures of both soft tissues and bone.
So imaging is crucial, especially the more sensitive types early on. What about diagnostic criteria? Is there like a checklist?
There are classification criteria, primarily the 2010 Acreolar criteria. It's important to note they're for classifying disease likely to become chronic and erosive, more than for initial diagnosis in every single person.
Right.
But they're very influential. They use a scoring system based on 4 things.
Okay, what are they?
1, joint involvement, how many joints, and whether they are small joints like hands, feet, or large joints. 2, serology, the results of RF and ACPA tests, negative, low positive, or high positive. 3, acute phase reactants, whether ESR or CRP are elevated. And 4, duration of symptoms, typically 6 weeks or longer.
And you need a certain score.
Yes, a score of 6 or more out of 10 classifies someone as having definite RA. The big shift with these 2010 criteria compared to older ones was the emphasis on serology, especially ACPA. and catching the disease before major X-ray damage occurs, allowing for earlier, more effective treatment.
That makes sense. Intervene before the damage is done. And finally, ruling other things out.
Absolutely critical. Differential diagnosis is key. RA symptoms can overlap with many things. Crystal arthritis like gout or pseudogout joint fluid analysis is definitive here. Osteoarthritis pattern, stiffness duration, lack of symmetry help distinguish it. Lupus, SLE, often has other specific symptoms and antibodies. Psoriatic arthritis, look for skin psoriasis or nail changes. Lyme disease, if in an endemic area, specific blood tests. Reactive arthritis often follows an infection, different joint pattern. Even things like hepatitis C can cause arthritis. Sometimes someone might have inflammatory arthritis but not clearly fit RA or another specific diagnosis yet that's sometimes called undifferentiated arthritis, and these patients need close monitoring.
That's incredibly thorough. It really shows diagnosis is an active process of gathering evidence, using these specific markers like ACPA and 1433 as key clues, but always considering the whole clinical picture and ruling out lookalikes. Definitely not a simple blood test result. All right, so once that complex diagnostic process leads to a confirmation of RA, the focus shifts squarely to treatment. And the big questions are, is there a cure? What are doctors actually aiming for?
Right. And the first point, based on everything we know, is crucial. Currently, RA is not curable. There's no magic bullet that eliminates it completely.
Okay, that's important to state up front. But,
and this is equally important, RA is very treatable, hugely treatable compared to even a few decades ago. The main goals of treatment are to reduce pain, control and decrease inflammation, prevent or slow down joint damage and disease progression, and ultimately improve or maintain overall function and quality of life.
so it's about managing the disease effectively long-term.
Exactly. And the whole treatment philosophy has changed. The mantra now is early and aggressive treatment. Don't wait for damage to happen. Get the inflammation under control quickly and comprehensively.
That makes sense. Attack it early.
Yes. It typically involves a team approach with a rheumatologist leading the way. And it requires a long-term plan that includes medications, absolutely, but also vital lifestyle adjustments, which we'll talk about later. Constant monitoring, regular follow-ups, and really open communication between the patient and doctor are essential for success. Reporting new symptoms, discussing if a medication isn't working well enough, that's all part of it.
Okay, let's get into the medications. Our sources mention 5 main categories.
Right, let's break them down.
NSAIDs, non-steroidal anti-inflammatory drugs. Think ibuprofen, Advil, or naproxen aleve, over-the-counter, or prescription versions like Celebrex.
What do they do?
They primarily decrease pain and inflammation. Good for symptom relief, reducing pain and stiffness. But, and this is key, they do not change the underlying disease course. They don't stop the joint damage from progressing. They manage symptoms. Also need caution with GI, heart, or kidney issues.
Okay, so symptom relief, not disease modification. Got it. Next.
Second, steroids or corticosteroids like prednisone. These are powerful, fast-acting anti-inflammatories. Very useful early on to quickly calm down inflammation while waiting for other slower-acting meds to kick in, which can take weeks or even months.
How are they used?
Can be taken as pills or sometimes injected directly into a particularly inflamed joint for targeted relief with fewer body-wide side effects. The goal is always the lowest effective dose for the shortest possible time because long-term steroid use has significant side effects: weight gain, high blood pressure, diabetes risk, bone thinning, etc.
Right. Powerful, but need to be used carefully. Okay, category 3.
This is the real cornerstone. Traditional DMARDs, disease-modifying anti-rheumatic drugs. The name says it all. They aim to modify the disease. They work by suppressing the overactive immune system more broadly than steroids, slowing down the disease process and helping to prevent or limit that irreversible joint and tissue damage.
Examples.
The most common, and often the first one tried, is methotrexate, usually taken once a week. It's considered the anchor drug for RA treatment by many rheumatologists. Other traditional DRRs include hydroxychloroquine, Plaquenil, sulfasalazine, leflunomide, Arava, and azathioprine.
And they really slow the disease.
Yes, studies show they improve symptoms, reduce joint damage progression on imaging, and improve function. They can induce remission in a significant number of people, maybe around half, but they take time to work weeks to months and require regular monitoring for potential side effects involving the blood counts, liver, or lungs. Taking folic acid alongside methotrexate can help reduce some common side effects like nausea.
Okay, DRs are key. Then what's category 4? Biologics.
Yes, biologics or biologic response modifiers. These are also technically DMARDs, but they represent a more targeted approach. They're complex proteins, often antibodies, made from living organisms.
Targeted how?
Instead of broadly suppressing the immune system like traditional DMARDs, biologics are designed to zero in on specific molecules or cells involved in the inflammatory cascade, like TNF, tumor necrosis factor, or interleukins like IL-6 or IL-1, or specific immune cells like B cells or T cells. By blocking these specific targets, they disrupt the inflammation process more precisely.
So potentially more effective or with different side effect profiles?
Potentially, yes. They are often used when traditional DMARDs like methotrexate aren't effective enough or if someone can't tolerate them. Examples include well-known drugs like Humira, Enbrel, Remicade, which are TNF inhibitors, Rituxan, a B-cell inhibitor, Orencia, a T-cell inhibitor, Actemra, an IL-6 inhibitor. They're given by injection or infusion.
Any special considerations?
Yes, because they modulate the immune system, there's an increased risk of infections. Testing for latent tuberculosis, TB, is essential before starting most biologics, as they can reactivate it. They're also generally much more expensive than traditional DMARDs. Sometimes their effectiveness can decrease over time, or side effects can emerge.
Do they work better with methotrexate?
Often, yes. Combining a biologic with methotrexate generally leads to better outcomes, higher response rates, better functional improvement, higher chance of remission than using either alone for many patients. They might also help with fatigue.
Okay, targeted biologics. In the fifth category, JAK inhibitors.
Right, the newest class. JAK inhibitors like tofacitinib, amelgans, baricitinib, upadacitinib, Rinvoq. These are small molecules taken as pills, so sometimes called oral biologics, though technically different.
How do they work?
They work inside the immune cells. They block specific enzymes called Janus kinases, JAKs, which are crucial for transmitting inflammatory signals within the cell. By blocking JAKs, they interrupt the signaling pathway that leads to inflammation.
So another way to target inflammation, but as a pill.
Exactly. Similar precautions apply regarding infection risk, TB testing, and monitoring for side effects, which can include things like changes in cholesterol levels or blood counts, and there have been some safety signals regarding cardiovascular events and clots with some JAK inhibitors, so careful patient selection and monitoring are key.
It sounds like there are many options now. Are they used together?
Yes, combination therapy is very common. Methotrexate plus a biologic is a standard approach. Also, triple therapy using methotrexate, sulfasalazine, and hydroxychloroquine together has been shown in studies to be as effective as methotrexate, plus a TNF inhibitor biologic for many patients, offering a less expensive alternative if biologics aren't suitable.
That's good to know there are effective non-biologic combos too. So here's where it gets really interesting. Are there newer things on the horizon? Any exciting research?
Absolutely. Research never stops. Some intriguing areas include hydrogen therapy. Early studies, like one using H2-infused water, showed some symptom improvement, but it's very preliminary. Targeting fibroblast-like synoviocytes, FLS. These cells in the joint lining become aggressive villains in RA, driving damage. Developing therapies to specifically target or reprogram these FLS cells is a very hot area of research with huge potential. Genetics and precision medicine. Continued research into the specific genetic variations influencing RA risk and severity is fueling the development of even more targeted therapies, aiming for personalized treatment approaches. The gum disease link. Researchers are really digging deeper into how bacteria from gum disease might trigger or worsen RA, potentially opening up new prevention or treatment strategies focused on oral health.
Wow, targeting those specific FLS cells sounds incredibly promising.
Yeah.
It really shows the shift from just dampening inflammation broadly to trying to hit the disease process at its core, even at the cellular level. The evolution in treatment is remarkable. We've covered the medical treatments extensively, which is obviously crucial. But RA isn't just managed with pills or injections, right? How much impact do diet and lifestyle choices have?
They have a huge impact. Our sources really emphasize that lifestyle management is a critical partner to medical treatment. It's not an either, it's a both-hand approach for the best outcomes. And we need to remember RA affects your whole life, physical and mental well-being, beyond just the joints.
So let's start with diet and nutrition. Why is it so important in RA?
There are a couple of key reasons. First, as we touched on earlier, excess body fat, particularly visceral fat, actively produces inflammatory cytokines chemicals that fuel the fire of RA. So maintaining a healthy weight is crucial purely from an inflammation standpoint. Second, extra weight puts direct mechanical stress on already sore joints, especially weight-bearing ones like knees and hips.
Makes sense. So what kind of foods are beneficial?
The general theme is an anti-inflammatory diet. Think whole, fresh, unprocessed foods rich in antioxidants.
Like what specifically?
Lots of vegetables, especially leafy greens and legumes. Fruits, particularly berries. Some studies suggest diets high in vegetables improve symptoms, while high meat diets might worsen them. Using spices with known anti-inflammatory properties is great too. Ginger and turmeric, with its active compound curcumin, are standouts. Cinnamon also shows some promise in lab studies.
What about fats? Aren't some fats good?
Yes, essential fatty acids, particularly omega-3s, found in fatty fish like salmon, mackerel, sardines, flax seeds, chia seeds, and walnuts. Omega-3s have well-documented anti-inflammatory effects. Some studies suggest fish oil supplements might reduce morning stiffness or the number of painful joints, though the evidence isn't uniformly strong across all studies for all outcomes. There's also gamma-linolenic acid, GLA, and omega-6 found in borage oil or evening primrose oil, which some studies suggest can help reduce joint pain and swelling.
Okay, so focus on plants, spices, healthy fats. What about foods to limit or avoid?
Generally, limit foods that can promote inflammation. That means reducing processed foods, foods high in saturated and trans fats, refined sugars and flours, excess salt, maybe red meat. The connection between red meat and RA is debated. Some studies show a link, others don't.
What about gluten or alcohol?
Gluten might be an issue for some individuals with RA, possibly acting as an antigen or contributing to gut permeability issues. Some people find improvement on a gluten-free diet, but it's not a universal trigger. Alcohol is complex. As we noted, some recent studies surprisingly suggest moderate alcohol intake might even be associated with lower RA risk or severity, contradicting older ideas. But excess alcohol is generally not advisable for overall health. It's likely very individual.
Are there specific dietary patterns that seem helpful?
The Mediterranean diet often comes up rich in fruits, vegetables, whole grains, legumes, nuts, olive oil, and fish. It aligns well with general anti-inflammatory principles. Some people explore elimination diets to identify specific food sensitivities, sometimes guided by allergy testing, though this should be done carefully, ideally with professional guidance. Vegan diets have also shown benefits in some studies, possibly due to high fiber, antioxidants, and positive changes in gut bacteria. And don't forget, hydration, drinking plenty of water is always important.
Okay, diet is clearly a big piece. What about exercise? Is it safe if your joints hurt?
Yes, not only safe, but highly recommended. It might seem counterintuitive if you're in pain, but regular, appropriate exercise is crucial for managing RA.
Why? What are the benefits?
It helps maintain joint mobility and flexibility, strengthens the muscles that support the joints, reduces stiffness, improves balance, boosts energy levels, improves sleep, and significantly lifts mood and combats fatigue. Exercise actually helps nourish the cartilage by promoting synovial fluid circulation.
What kinds of exercise are best?
Focus on low-impact activities. Think stretching for flexibility, strengthening exercises, using light weights or resistance bands, and aerobic conditioning like walking, swimming, cycling, especially stationary bikes, water aerobics, tai chi, or gentle yoga. The key is consistency and listening to your body. Don't push through sharp pain. Physical therapy can be incredibly helpful in designing a safe and effective program and teaching joint protection techniques.
So movement is medicine, basically.
In many ways, yes. Balancing activity and rest is key.
What else in daily life? Sleep, mental health.
Sleep is huge. RA fatigue is often profound, and poor sleep makes it worse. Good sleep hygiene, maybe some relaxation exercises before bed is important. And mental health cannot be overlooked. Living with a chronic, painful condition like RA understandably increases the risk of anxiety and depression. Recognizing this, taking time for stress management, maybe meditation, mindfulness, and seeking professional support like therapy or counseling when needed is vital.
Are there any other practical tips? Posture, gadgets?
Paying attention to posture helps reduce strain on joints. Taking breaks if you sit for long periods. Using assistive devices if needed can make daily tasks easier and protect joints. Some people find compression gloves helpful for hand symptoms, though the evidence is mixed.
What about supplements besides fish oil? Any vitamins, herbal remedies?
Vitamin D deficiency is common in RA, so checking levels and supplementing if needed is often recommended, though whether low D contributes to RA or is a consequence isn't fully clear. A general multivitamin might be reasonable. For herbal medicines, the American College of Rheumatology generally advises against them due to lack of strong scientific evidence for effectiveness and significant safety concerns. Natural doesn't mean safe. Some herbs can interact badly with RA meds or have direct toxicity. Always discuss any supplements with your rheumatologist.
Good advice. One last thing, vaccinations.
Yes, very important. People with RA, especially those on immunosuppressive medications, are at higher risk of infections. So staying up to date on recommended vaccinations like the annual flu shot, inactivated version, pneumococcal vaccine, and the shingles vaccine, specific type depends on meds, is crucial protection.
So what does this all mean? It really paints a picture of needing a truly holistic approach. Medication is the foundation for controlling the disease, but optimizing diet, staying active, managing stress, getting good sleep, these are all powerful tools you can use to feel better and live well with RA.
Exactly. It's about empowering patients to be active participants in their own care, working alongside their medical team. Hashtag tag to 7, prognosis, and the future of RA.
We've covered a lot of ground. As we look towards wrapping up, let's talk about the long-term picture. What's the typical prognosis for someone diagnosed with RA today? Does it inevitably get worse, and can it actually go into remission?
The disease course is highly variable. For some, it might be relatively mild, but for most people, RA is a progressive disease if left undertreated. Symptoms tend to wax and wane, periods of higher activity, or flares, alternating with periods of lower activity. Spontaneous remission, where the disease just disappears on its own without treatment, is rare.
But remission with treatment is possible.
Yes, absolutely. Achieving remission, or at least low disease activity, is the primary goal of modern treatment. And we have tools to measure this, like the DACE-28 disease activity score, which combines joint counts, information markers like ESR or CRP, and the patient's own assessment. There are other scores, too, like the SDAI and CDAI and formal acrylar remission criteria. The aim is to get disease activity as low as possible, ideally to 0.
Are flares predictable?
Not usually, unfortunately. Flares can sometimes be triggered by things like stress, overexertion, infections, or sometimes seem to happen for no apparent reason. Learning potential personal triggers and managing the disease proactively helps minimize them.
What about people who don't respond well to treatment?
There's a category called difficult-to-treat RA, D2T-RA. These are patients whose disease remains active despite trying several different types of treatments, including biologics or targeted therapies. Factors like genetics, smoking, obesity, and maybe even specific disease pathways can contribute to being harder to treat. It's an ongoing challenge.
Are there factors that predict a worse prognosis generally?
Yes, certain things are associated with a tougher course or more damage over time. These include persistent high levels of inflammation, synovitis, seeing early joint damage, erosions on imaging, having extra-articular features like rheumatoid nodules, testing positive for RF, and especially high levels of ACPA or 1433, carrying those specific HLA-DR4 shared epitope genes, having a strong family history. Starting with poor functional status, socioeconomic factors can play a role too. Consistently high ESR-CRP levels.
Okay, now the tough question. How does RA affect life expectancy?
It's true that, on average, RA has been associated with a reduced lifespan, maybe by about 3 to 12 years compared to the general population. Higher mortality risk is linked to factors like younger age at onset, longer disease duration, having other health problems, comorbidities, and indicators of severe RA, like poor function, lots of joint damage, or organ involvement.
What's the main driver of that increased mortality?
A major factor is the significantly increased risk of cardiovascular disease, heart attacks, and strokes. As we discussed, the chronic inflammation of RA itself seems to accelerate atherosclerosis, independent of traditional risk factors like cholesterol or blood pressure. This really underscores why getting the RA inflammation under control is so vital, not just for joint health, but for overall survival.
Do the newer treatments like biologics help improve life expectancy?
That's the hope, and there's some evidence suggesting they might be reducing the cardiovascular risk and potentially improving longevity, but it's still being studied long term. It's complex, as some treatments might affect cholesterol levels, for instance, though often raising the good HDL cholesterol as well. But the general principle holds. Better disease control likely leads to better long-term outcomes, including cardiovascular health.
So looking ahead, what's exciting in ongoing research that might change the future for people with RA? Here's where it gets really interesting.
There's a lot. Researchers are digging much deeper into that periodontal disease link, trying to pinpoint exactly how oral bacteria might trigger autoimmunity. The role of the gut microbiome and intestinal permeability, leaky gut in arthritis, is another huge area. Could manipulating gut bacteria become a future therapy? Understanding the role of microRNAs, tiny molecules that regulate genes, might lead to new biomarkers to predict treatment response or even new therapeutic targets. And as mentioned, therapies aimed directly at those misbehaving FLS cells in the joint lining hold enormous promise for stopping damage at its source.
It sounds like the focus is increasingly on understanding the root causes and finding more precise ways to intervene early and effectively. Hashtag outro sap. This has been a really comprehensive deep dive. We've journeyed from defining RA as this complex autoimmune condition, distinct from OA, through its web of causes, its wide-ranging symptoms both in and out of the joints, the nuances of diagnosis, and the incredible evolution of treatments aimed at remission.
Mm-hmm.
We've seen how crucial early diagnosis and tailored, often aggressive, treatment are, but also how powerful lifestyle choices, diet, exercise, stress management can be in managing the condition day to day.
Absolutely. It's a partnership.
And while there's currently no cure, the message seems to be one of significant hope. The advancements offer a real chance to control the disease, prevent damage, and maintain a high quality of life. Being informed is definitely power here.
It really is. And perhaps a final thought to leave with our listeners. As we've explored today, rheumatoid arthritis really is a fascinating, if challenging, story of complex biology, environmental interactions, and this ongoing quest for medical precision. We see how genes, lifestyle, even microbes in our gut or mouth can influence this disease. So considering all that, how might our rapidly growing ability to personalize medicine-tailoring treatments based on an individual's unique genetic makeup, biomarkers, maybe even their microbiome, coupled with this deeper understanding of specific cellular players like those FLS cells, how might all this fundamentally reshape not just how we treat RA, but potentially how we approach preventing complex chronic diseases altogether in the future?
That's a powerful question indeed. Thinking about prevention based on this deep understanding. Fascinating. Well, thank you so much for joining us on this deep dive into rheumatoid arthritis. We truly hope this detailed exploration helps you, whether you're navigating RA yourself, supporting someone who is, or simply seeking to understand it better. Until next time, keep diving deep.